Kia ora koutou, ko Claire Underwood, toko ingoa. My name is Claire Underwood and I'm a Principal Advisor for the Health Cert team at the Ministry of Health. I will be giving a presentation on the infection prevention and antimicrobial stewardship subsections of Napa Era. I have previous experience working as an infection prevention and control clinical nurse specialist in the public and private sector, as well as now working for Health Cert for nearly a year. So we'll go straight into the presentation. You'll be aware that Napa Era Health and Disability Services Standard came into effect on the 28th of February in 2022. This was approved under the Health and Disability Services Safety Act of 2001, and it replaces several other standards, and the review process to bring Napa Era to life took 2.5 years. The format of Napa Era is illustrated in this slide here, and I've chosen section 5. The criterion here is expressed as 5.1.1, and this actually illustrates the section, the subsection, and the criterion. So the section is section 5, the subsection is 5.1, and the criterion illustrated here in this slide is 5.1.1. It's slightly different from the old standard. Key changes to Napa Era, and particularly to the infection control requirements, is that it is now referred to as the Infection Prevention and Antimicrobial Stewardship section. It has an increased focus on clinical governance, and the requirements will remain dynamic and reflect current best practice. When we talk about remaining dynamic and best practice, this reflects that Napa Era will be in place for a long time and that best practice guidelines will likely change. And these will be the ones that will be referred to by health and disability providers and the auditors when they're auditing. Just a note now on the wording and definitions included in Napa Era. The word shall refers to requirements that are essential for compliance. Should refers to practices that are advised or recommended. In IP refers to infection prevention, and AMS refers to antimicrobial stewardship. If you look on pages of 2 to 11 of Napa Era, you will find an extensive list of definitions used in the document. Early on in the rollout of Napa Era, we had some feedback from providers and auditors about governance. The important thing to remember is that governance will be different depending on the size and scope of the facility and the level of risk. Another way of thinking about governance is how decisions are made for your facility or organisation, particularly for smaller providers that may not have large governance bodies. This refers to the approach or decisions on how decisions are made. Consider whether they are meaningful, documented, and communicated. This is an example of a page taken from the infection prevention section. And this is just to illustrate the person-centered approach that was incorporated into the creation of Napa Era. And as you will see, it will have a people statement, a treaty focus, and then it will give you guidance on what you will be expected to see if you attain this part of Napa Era. A key feature of Napa Era is that treaty requirements are embedded throughout the standard as you go through. Te Parangi, the Maori Partnership Alliance, developed the treaty requirements as part of the review of Napa Era and have continued to provide advice and guidance in this first year of implementation. So moving now very swiftly to subsection 5.1. This statement is the outcomes you can expect to see when the section's criteria are met. So this gives you, the providers, the guidance of what your service should be aiming to achieve. Subsection 5.1. Our governance is accountable for ensuring the IP and AMS needs of our service are being met, and we participate in national, regional IP and AMS programs and respond to relevant issues of national and regional concern. So we'll break this down a little further now with the next slide. Subsection 5.1 in practice. There are 4 criteria in this subsection, and I will just go through some of the things that you can expect us to be implementing in your service. Have a think about the key elements of what it means to have an IP and AMS program and what governance will look like for you. Particular criteria are focused on committees and group actions regarding your infection prevention and AMS program. How often are plans reviewed, for example? How is the committee accessing expert advice? And how are infection prevention and antimicrobial stewardship issues raised to governance level? Another thing to consider in this first subsection is the management of adverse events. How are these managed and reported on? And these are specifically infection prevention and AMS related events. Think about plans and policies. They need to be appropriate to the size and scope of the service and the degree of risk, and everyone will have a slightly different size and scope to their service and different needs of the people that they're serving. When you are seeking expert advice, this might be from the general practitioner for aged residential care facilities and residential disability providers. For larger organisations, it may be that your IP advice is from a national governing board. Especially for private and public hospitals, it might be the infectious disease physicians that provide expert advice to you. And whatever your process is it clearly documented in your infection control plan? Some of the criteria in this subsection where we've seen corrective actions, it is the plan and the link to governance that has been missing. Now moving on to subsection 5.2. There are 13 criteria in this subsection, so I will do several slides for this. Firstly, looking at 5.2.1 and 5.2.2, the initial statement about what this is looking at is we develop and implement an infection prevention program that is appropriate to the needs, size, and scope of our services. The way that this can be implemented and the way that you can think about doing this is thinking about the requirements for the person or people who are responsible for implementing the infection prevention program in your facility or organisation. Key things to think about are the knowledge base that those people need and their educational requirements to do the job. And if that person or team are supported by governance and the management team within the facility. Have a think about how this can be reported and whether there are links to quality improvement plans, and really also think about whether the service have access to everything that they need to do to enable them to do their job efficiently, particularly having access to the results of consumers is actually a very fundamental need. Moving on to 3 more criteria within subsection 5.2, 5.2.3, 5.2.4 and 5.2.5. These criteria really explain themselves, and they're about the policies and procedures that guide and inform infection prevention and control and antimicrobial stewardship. If you look in Napa Era, you will see that there's some very clear guidance on the type of policies that are required for an infection prevention and control service within your facility or organisation. And if the last 2 years have taught us anything during the COVID-19 pandemic, it is that infection prevention policies are a requirement for BAU work at any time. Napa Era gives a good example of those policies that you might need. And this work also extends to pandemic planning and work streams such as personal protective equipment and having adequate supplies and those things to do associated infection prevention and control work. So moving on now to criteria 5.2.6, 5.2.7 and 5.2.8. These criteria are also fairly self-explanatory. Much of the work that's completed around infection prevention is about the prevention aspect of the work IP teams can complete during their daily work. And these criteria are related to how education is completed for your facility or an organisation and how it's built into your overall education plans. Procurement and the purchasing of new equipment is very important for the prevention aspect of infection prevention. Have a think about whether your IP team have a say in how this is done. Similarly, the way in which healthcare facilities are constructed and built is very important. So there needs to be consultation with infection prevention personnel and teams before there are new builds in a facility or organisation. Also think about how you source IP expertise for new builds and refurbishments. Now, remember to keep a focus when you are thinking about these things on the size, scope and complexity of the service you are working in. A small 5-bedded facility is very different to a public hospital and also very different to an AIDS residential care service. Really think about what you actually need for the people that you are serving. Still within subsection 5.2, but moving on to the criteria that deal with the management of reusable medical devices. This is a very important feature of infection prevention work. Now, there is a guide here to give you an example of the types of things to consider for these criteria. And remember once more that this is applied to the size and scope of the provider. Reusable medical devices are different for everybody. Have a think about whether there is space to do this in your organisation, and are there policies and evidence-based procedures that are reviewed regularly. Airflow is something that comes up for larger public hospitals and private surgical hospitals. Having educational resources in Paerewa is also a new requirement of the standard. Please note that 5.2.10 is not applicable to residential disability, mental health and addiction services. Moving on now to subsection 5.3. This is the focus on the Antimicrobial Stewardship program within this IP section. Antimicrobial stewardship is really about the safe prescribing and management of antimicrobials. So the overall statement here is that we provide responsible antimicrobial prescribing and implement an AMS program that is appropriate to the needs and size and scope of the service. And 5.3.1 is currently not applicable to residential disability and mental health and addictions. Just to give you a little bit more information on this and some things to think about, responsible use of antimicrobials means a commitment to using them appropriately and knowing the risks associated with poor use. And a key feature of this is how this part of your work is governed and how it's supported. Having a policy is a requirement for all providers, but this is where the size and scope is really applicable and relevant to how you are achieving it. Wherever you work, you know your clients' and residents' needs and the risks to the demographic. What is the role of your GP in this service? I got our analyst to look at some of the corrective actions for this subsection, and things noted to be missing for providers have been the lack of an AMS program and committee meeting minutes and guidance documents for this work. Another thing that you might find useful is the sector guidance for this subsection. This recognises that facilities don't always have direct control over prescribing, but you can have some influence on promoting how things are done in your facility. There is a lot of work that can be done to reduce inappropriate prescribing by preventing infections in the first place. Discouraging lab testing without clear evidence of infection and treating an infection in an approved way and within an approved time period are key features of AMS. Moving on to 5.3.1, 5.3.2 and 5.3.3. Just a little bit more guidance here about how you can adhere to this section. Now, do the contents of your policy work in action for you? Is it evidence-based? And if it is, then it's going to need updating and require review. So how is this going to be done? Will the auditor be able to see how this applies to your service through the sampling process that they use? One of the most important features of antimicrobial stewardship, as I have previously mentioned, is whether prescribing is appropriate. Some of the corrective actions that we found in this criterion have been around the lack of policies and procedures and the wider involvement of the chief operating officers or managers. Moving on to subsection 5.4. So the overall statement here is about surveillance. And this is what we're expecting for this subsection. We carry out surveillance of healthcare acquired infections and multi-drug resistant organisms in accordance with national and regional surveillance programs, agreed objectives, priorities and methods specified in the infection prevention program and with an equity focus. This is about surveillance of healthcare acquired infection. Now, this isn't new. It's just expressed differently in Napa Era, but this is something that people have been doing for a long time. And it won't be a surprise to you because you know your service and you know the needs of your service. But when considering how an organisation acts on surveillance, consider how an outbreak is managed and detected. What does this look like in practice? And how are you monitoring multi-drug resistant organisms? Does the surveillance that you capture indicate that it's relevant for the population that you are serving? Remember that one size does not fit all, and you will know and understand the surveillance needs of your patients, residents, or clients. Some private surgical hospitals and public hospitals will be involved in national programs around surgical site infections and also hand hygiene and also capturing infections caused by specific bacteria that are related to quality improvement projects by the Health Quality Safety Commission. We wouldn't expect those types of things to be being done in smaller organisations. So have a think about and know what is appropriate for your service. Also have a think about how you're analysing your surveillance data, however big or small it is. Coming back to the cultural requirements of this, are the practices that you're doing culturally safe? Are you also collecting ethnicity data? And just remembering that there are some criteria that are not applicable for people in this section, and 5.4.3 is not applicable to utility services. Just moving on to the last subsection within the IP and AMS section, and that's 5.5. And the overall statement is, we deliver services in a clean, hygienic environment that facilitates the prevention of infection and transmission of antimicrobial organisms. 5.5.1 to 5.5.5 are about the healthcare environment. And again, once more, very similarly to the surveillance of healthcare infection, this isn't really new. So this is all about the healthcare environment. And once again, you know what is going to be appropriate to you. A couple of pictures here. I've got a aged residential facility, and I've also got what looks like a hospital ward in a public hospital. So we're serving a lot of different people. Have a think about your practices related to safe handling and disposal of waste. How is cleaning done for your organisation? Does the policy guide practice? How often is it reviewed? If you're doing cleaning audits, that's fantastic, but who are they reported to and who's actioning any problems that may be found? The safe handling and storage of laundry is a very important feature of infection prevention. And also, is there any testing for the environment that is completed for your facility or organisation? How often is it reported and acted on? Another feature to think about with cleaning is if it's outsourced to a private company or provider, how is this monitored? And are you involved in the policies and the audits that may be done internally? So just bringing this session to a close now and thinking about some of the challenges that may be there for your particular organisation or facility. Just to note that aged residential care and residential disability services are very different to public and private hospitals. The size and scope of services varies throughout New Zealand, and the auditors undertaking audits always recognise this when they're doing an audit in your facility. As I have said throughout this, the AMS and IP should meet the needs of the residents receiving the service. And ultimately, what this section and criteria are about is making sure that antimicrobial stewardship and infection prevention meets the needs of the residents receiving care. And that brings our presentation to an end. I'd just like to direct you to submit any questions and queries to the certification inbox. The email address is here on the slide, and some useful resources are detailed below, specifically the Napa Era standard, the sector guidance, and the mapping analysis. Otherwise, it just leaves me to say thank you very much for listening, and ka kite.